Hi everybody, my name is Peter Malyaros. Welcome to this keynote, which is going to be delivered at the first conference of sports injuries in June 2024 in Crete. And the title is Exercise and Appropriate Loading Are the Best Strategies? And it's posed as a question. So we're going to explore that question. I want to disclose that I do work full-time as a professor at Monash University, but I also derive some income from Orthosport Victoria, where I work as a physiotherapist, and I have received funding from Shockwave companies before to do research, and I'm not talking about Shockwave today. So I'm going to try and defend the following claims. Exercise, and I'm defining that as therapeutic exercise, is the best strategy for tissue adaptation. And the second claim is that appropriate loading is the best strategy for pain. And I'm going to define a little bit more about appropriate loading as we go through. We know that our tendon patients primarily come to us with pain. That's their primary concern. They also have commonly reduced function, impaired ability to do things, and that can sometimes be really profound. We've done a lot of qualitative work, particularly with Achilles tendinopathy. People report things that really are surprising sometimes. There's a deep impact in terms of their ability to do things that are life-affirming, to do things that define them, to participate in social activities, to participate in engagement with family, because they are unable or fearful of causing problems, further problems for their tendon problem. So we need to appreciate the impact that tendinopathy can have, and we'll try and keep that at the back of our minds as we go through what's going to be really a more focused look at active strategies and some of the evidence for those active strategies. But to sort of start that discussion, let's go way back. Let's have a little bit of a history tour through some of the evolution in thinking with tendinopathy. So we know that if we go back to the 70s and 80s, the term that we used to use was tendinitis. And we know that tendinitis has a specific meaning. It means that there's an inflammation within the tendon, and the key problem with calling it tendinitis is that it might then lead to some people thinking that if they rest or they take anti-inflammatories, that might be enough. Now we know that commonly those types of interventions are not enough. So we do need to be thinking about the impact of terms like that. So we had a consensus in 2019. The paper was published where a group of experts from around the world agreed that we shouldn't use the term tendinitis, and it should be, or tendinosis for that matter, and it should be things like tendinopathy, which broadly mean pain in the tendon, but not making any assumptions about what is underlying that pain. But way back before that, Nicola Maffulli and colleagues already suggested that we should be using the term tendinopathy, and that was back in 1998 that this paper was published. I had a quick look on Google Ngrams, which just gives you the words that are representative online at different times, and what you can see is that tendinitis was really in vogue throughout the 70s and the 80s and the 90s, and then peaked around 1998, precisely at the time when Nicola Maffulli and colleagues published this paper. So it's been quite impactful, and you can see that has gone down, and then tendinopathy has slowly gone up and has now overtaken it. Okay, so tendinopathy is the preferred term, and this started getting us thinking about different ways. So it shifted the focus from we're just going to take anti-inflammatories and we're just going to rest and things will be better, more towards active approaches. And probably the most influential of these over the last 3 or 4 decades has been eccentric training. So eccentric training was first introduced by a surgeon, Håkan Alfredsson, from Sweden, and he published the first account of the way that they were doing eccentric training probably in the late 90s, and so getting on to almost 30 years now. And the thing that they were doing differently is they were loading it really heavy. They were loading it heavy. They were trying to get a real adaptive response. So this was thinking about how can we develop as much loading for the tendon as possible. So it was very much focused on trying to heal the tendon, and it did work. So there were improvements in people that tried this sort of loading. And eccentric training just means that you're focusing on the downwards phase. You're not going upwards, you're just going on the downwards phase, and it did really work. One of the things that we need to question and think about with any treatment is, how does it work? We know that exercise treatment, if you give it to a bunch of people, over time they will have less pain. We know that from countless studies. And we also know that that from compiling of all the different research studies that are out there. This is a systematic review where they looked at how much better are people getting over time, and they looked at they defined much better as improvements in pain and improvements in self-reported function. And they noticed that, or they found that people, if you look at them at 12 weeks, on average, people are getting better with these active treatments, this exercise treatment. Not only eccentrics, but also other exercise treatments. So people are getting better. The thing that we need to question is, how are they getting better? So what are the mechanisms? So whenever we do something in a clinical context, there are different mechanisms that could explain that improvement. One of them is natural history. So it might be that people are just improving over time. It might be that there are some treatment effects. So this exercise, does do something, and it does improve people in some way. It might be that there are placebo effects. So people may have expectation-based effects because they're having a treatment. You're thinking, okay, I'm having this treatment, I'm probably going to improve, and you end up having that sort of placebo mechanism becomes more active. And then there's also other contextual effects. So this is contextual effects related to the environment, related to the trust you have in the people you're seeing. Those types of things can also influence outcome as well. So that's important to keep in mind when we're looking at exercise. We do know very clearly that it works, or it seems to work over time. We don't know much about how it works. What are the mechanisms, if it does work? So we're going to make the assumption today that treatment does have an effect. And now we're going to explore, so we're going to go into this part of it a little bit more. We're going to ignore the other non-specific effects. We're going to focus on these specific effects, and we're going to ask the question, if we do exercise to someone and they get less pain, what happens in the middle? So what are the mechanisms for that person improving? So we're going to think about these mechanisms. The way I'm presenting this today here is, we're going to think about them in the way that we have thought about them over time, as we have started to learn more about tendinopathy over the last 2 or 3 decades. So initially, and this goes back to the Hocken-Alfredson eccentric training that we talked about earlier, initially it was very much focused around structural changes. So we thought that there's Doppler, which is just a way of showing blood vessels in the tendon on ultrasound, and there's also structural changes that we can see on various types of imaging like ultrasound and MRI. Initially we thought that these are the things that are likely to be changing, and this was 25 years ago. And Hocken-Alfredson and his radiologist Lars Oberg contributed to this research as well. I was a young PhD student, probably around about early 2000s, when we had a visit from Hocken-Alfredson as well as Lars Oberg to our centre in Melbourne, and they were telling us all about the treatment they were doing. And this was the eccentric training, trying to influence the Doppler vessels. This is the Doppler colourful vessels in the tendon that we know are pathological, and at that time we thought they were related to pain very closely. And so what we thought was, needed was to try and mechanically affect these vessels, and this eccentric training was really conceived as a way of mechanically disrupting those vessels, which will disrupt pain, influence maybe some of the pain fibers growing into the tendon as well. So there was a very mechanical, tendon-focused view of how the exercise potentially made pain better. So that was way back, as I say, in the early 2000s. Let's fast forward now. This is a randomized trial that we have just completed, which isn't published as yet, but this is secondary analysis from some of the data from that trial, where we were able to measure change in Doppler, so change in those colourful images that we saw on ultrasound, and change in VISA, which is just pain and function, and we can see that there's virtually no relationship. Well, there is no relationship between those two outcomes. So if you improve in terms of your if your Doppler gets better, it doesn't mean it's related to how your pain is changing. Okay, so we now have a clearer idea that some of these structural changes are probably not the thing that is driving the improvement. So what else could it be? Well, one of the other things that we then turned to in trying to find mechanisms were things like neuromuscular changes and also tendon adaptation. So let's go through these in a bit more detail. So by neuromuscular changes, that's quite a broad term. It includes things like people getting stronger, people getting bigger muscles, people able to activate their muscles better. So changes really to how you're able to function in terms from a muscle point of view. And then tendon adaptation, the main outcomes that people look at here are things like tendon stiffness. So tendon stiffness is really just giving you a measure of how resistant a tendon is to force. So a stiffer tendon, if you put a certain force through it, it's not going to stretch or strain as much. A less stiff tendon or a more compliant tendon will strain more for that same given force. Okay, so stronger tendon is going to be the one that is going to be straining less for a given force. So that was interpreted as good. That's something we should strive towards, and that's one of the outcomes that people started looking at. So then this is sort of around the time when we had another type of exercise for tendinopathy, and this was heavy slow resistance. And heavy slow resistance, the first paper was published in 2019. I still remember when that was published, there was big excitement about it. This was a better way of doing it, we thought, because now we're not just doing eccentrics that is very blunt in terms of muscle physiology, what we know about muscle physiology. We need to be doing this progressive approach where we're doing, higher repetitions, progressing to more intense lower repetitions. It progresses from 15 repetitions, like the eccentric program, more towards something like 6 repetitions where the load goes up, the volume goes down. This was good principles of strength and conditioning. So this must be, more on the right track, particularly if we're thinking that we need to get people's muscles working better. We need to get them functioning better. So then the group in Copenhagen who first came up with a heavy slow resistance training program, they tested it in a couple of trials. Now one was looking at patellar tendon, and the other one was looking at Achilles tendon. And what they found was really interesting. They found that there really wasn't many differences in terms of what patients were reporting when they had these very different exercise programs. So whether we give them eccentrics, which is not going to target the muscle as well, because it's not a real sort of, strength and conditioning program aimed at really getting, it probably does, if you do it well, lead to strength gains. But this new program was surely better at doing that. So if that was the way that if that is the thing that people need to improve, this is the thing that's going to make them better. But we didn't see that improvement. There wasn't that change that meaningful difference with this new program. We tried to tease this out a little bit more. This was a randomized trial, a pilot and feasibility randomized trial that one of my PhD students ran a few years ago. And what we looked at here was effectively there's 4 groups, as you can see, but you can separate them into 2. This was a higher intensity group where they maxed out at 6 repetitions. And then there was a lower intensity group that maxed out at 18 repetitions. So there was a big difference in intensity between these 2 groups. So we're thinking that maybe if intensity is important, we should be seeing more benefit in the groups that did the more intense exercise. But what we saw in terms of visa outcome, and bear in mind this is a pilot study, so I'm not reporting differences, I'm just looking at trends in the data at this point. What we saw is that there wasn't really a signal of difference in outcome between all those groups, even though they were very different in terms of intensity. So maybe intensity isn't the thing that is getting people better. We went a step further and we looked at the relationship between change in maximal voluntary isometric contraction. So this is basically how much force someone can produce isometrically. We looked at the relationship between that and change in visa, which is again pain and function. And what we found is that there wasn't any relationship that we could see at all. So these variables were not related, meaning that if you get stronger, that's not the thing that is driving your improvements in how you feel. Okay, so then that's not the thing that we should be looking for. A group in Germany has gone a little bit further with this. They've actually done a full-scale trial quite recently. It was only published a couple of years ago, and they compared a high-load intervention, so similar to our high-load groups. They compared that to actually, I should go back and just point something out here. As you would expect, the high-load groups in our trial did achieve improvements in strength more so than the low-load group. So they did have their maximal strength or maximal isometric strength was better at the end of the trial than the lower load groups, but that didn't relate to how they felt. And similar story for this trial that was done in Germany. They did a high load intervention versus an Alfredson intervention. You can see here, they found similar things for strength, but I'm going to focus on tendon stiffness. We didn't measure that. They did measure that, and they found that tendon stiffness improved only in the high load group. But again, the improvements in visa were similar across the board. So regardless of improvements in the tendon's ability to take load, the stiffness of the tendon, they still had similar improvements in pain as compared to the Alfredson program. So that was really interesting. So what can we derive from these studies? Adaptation may improve things like participation, function, or reduce recurrence. So it's important to strive for adaptation. So we can't just take away that side of improvement, because we know that people's tendons change and we know that their muscles change, and that might affect how they move and how they function and things they can do. So yes, we need to improve strength, and we need to try and improve the tendon stiffness and other outcomes related to the tendon as well. But the important point is that that's probably not the thing that's driving improvements in pain. Improvements in pain are probably related to other mechanisms. And that's based on the current evidence that we have. So what could these other mechanisms be? One of the other areas, and this is probably a more recent thing that people have been looking into over the last probably decade or so, particularly in the tendinopathy area where it's been a little bit slower, coming to this, is that we can also potentially see improvements in pain related to cognitive or psychological mechanisms, changes in how people think, changes in how people view their condition, changes in how people view their pain. So some of the constructs we measure here, things like catastrophizing, and catastrophizing really is that you're thinking about the worst potential outcome, the worst could possibly happen. If I do that, it's going to, definitely my tendon's going to rupture, or thoughts like that. Pain-related fear is thoughts that, your pain is potentially leading to damage. You shouldn't do too much because it might risk the pain flaring up. Sort of those thoughts about pain that often lead to people being less active, not doing as much, and then that has onward effects, and that often then can lead to the pain being amplified, because when you do start to do things, it feels worse. So these things might be the missing part of the puzzle in terms of what are the mechanisms. Now, we don't have a lot of evidence in tendinopathy for these mechanisms, but we do have a recent trial, and this was from another group in Copenhagen, in Copenhagen, I'm pretty sure, in Denmark at least. They published a randomized controlled trial looking at interventions for shoulder pain, people with rotator cuff related shoulder pain, and they had two groups. They had one group that did the standard type of exercise, and they had another group that did a bit more exercise. So they added a little bit more exercise into that additional intervention group. And what they found was really interesting. They found that when you added the exercise in, there wasn't much difference between the groups for some of those key outcomes, like Spady. Spady is the equivalent or similar to Visa for the shoulder, where it's looking at a composite pain and function outcome. And so they, in their main trial, they found there wasn't much difference. But then they teased that out more, and they looked for some of the variables that could explain difference in subgroups, I guess you can say. And these are what we call moderators. So a moderator is a variable that might change the outcome between those groups. And they looked at one of the moderators, which I'm just going to present here. They did look at other factors in their secondary analysis, which was published in 2023. But the one I'm going to focus on is pain catastrophizing. So they found that people that had higher scores on pain catastrophizing, actually had a worse outcome compared to the control group, and people that had lower scores on pain catastrophizing had a better outcome. So what this means, and now Spady, the lower the Spady score, the better. So what this means is that if you are someone that is catastrophizing more, and you're given this extra exercise, it's not going to work for you. So just throwing more exercise at someone without dealing with the context, i.e. how they are thinking about pain, how they're thinking about loading, how they're thinking about exercise, is probably not going to work. In fact, it might have the reverse effect. It might even make you worse. Whereas people with lower catastrophizing, they had a better outcome. So our goal as clinicians and patients' goal is to try and get to that point where you're understanding the condition, your catastrophizing is lower, and then loading is probably going to be effective in that context. Okay, so context is really, really important. So how does this work? How does the context work? Well, this is a model proposed by Smith et al., published in British Journal of Sports Medicine in an editorial in 2019. So pain is complex, and it's influenced by what we think, our cognitions, our experiences, and we can influence those. So one way of influencing those is education. We can talk to people about the belief, for example, that pain may be damaging, and that can influence their behaviour. And it can also influence their pain. The other way that we can influence pain is we can also use therapeutic exercise. And they were putting forward the view that maybe exercise works by challenging unhelpful beliefs. If you're fearful of doing things, but then you try something and it's not as bad as what you thought, that's going to challenge the belief that activity is bad. It's going to lead to new experiences. It's going to lead to different behaviours. It's going to challenge the threat response of pain, especially when we give people messages like a little bit of pain is okay. You don't have to worry about a little bit of pain when you're doing your rehabilitation or other exercise. So this is providing a mechanism by which potentially where people are starting to rethink, reconceptualize what's happening to them, and that can have an influence on their pain. That's just one model. There are other models, active inference, other models that can also explain from a mechanistic point of view how when we give people education or exercise, how they're changing their view of the world and how that influences their pain. Okay, so that may be helpful in explaining what we're seeing with some of these studies, like the Clausen study. So thinking about this further, I'm going to put forward now the proposal that what we might be successful with some people is just doing usual activities. Why do we even need to go to the point where we're giving people therapeutic exercise? If it is this mechanism of just gradually reaccustom yourself to doing the activities that you want to do, why don't we just go straight for those activities? Well, I think we can for some people. I think it's going to work just fine, and it does work just fine to target usual activities, and that might be sufficient for some people, and that's going to be specific to their goals, specific to their fears, specific to the activities that they need to get back to. And we can view this as a graded exposure approach, just in a gradual way, increasing their exposure to the activities that they need to do. And that most likely works through building confidence, building self-efficacy, building that ability to trust in those activities. There are, though, undoubtedly people that we also need to think about therapeutic exercise. And therapeutic exercise can work through the same mechanisms. So exactly the same mechanisms of building trust, self-efficacy, reducing pain-related fear. And I think the people that we do need to start this approach in are the people who initially are at a symptom level where they are unable to start with their usual activities because symptomatically they're too severe to start with those usual activities. So we need to take them back a step, reduce the load, and then think about starting with therapeutic exercise. Another group that you might consider a therapeutic exercise approach are the people that have impairments in terms of their strength. We know that these activities are power-based activities. We need a certain amount of muscle strength to achieve them. So therefore, building muscle strength here to facilitate some of these activities makes sense as well. Doesn't mean that it's going to help their pain, or it's necessary to help their pain, but it may help in the long term their ability and how well they do those activities. Okay, so there's a couple of reasons to think about starting a graded exposure down here versus just up here. Okay, so thinking about this more, I'm going to give you an example, and this is from a trial that was published in 2021. And what the authors of this trial did is they took the classic Alfredson eccentric protocol, and they compared that to a progressive 3-stage, or actually 4-stage program that involved isometric exercise followed by isotonic, followed by energy storage, followed by sport-specific activities. Okay, now this was actually proposed in a topical review sort of expert opinion piece that I wrote with some other people in 2015. The authors of this trial took that and said, hang on a sec, let's compare that to classic eccentric program. And lo and behold, they actually found a difference between the groups. And this is quite rare when it comes to comparison of two different exercise approaches. It's really rare if you look at the literature, regardless of the musculoskeletal condition you're looking at, to actually find that there are two exercise programs that lead to differences, particularly in things like pain. So you can see here that at 12 weeks, there wasn't any difference between the intervention group and the control group, but then at 24 weeks, there was a difference, and there was a better outcome, better improvement in pain and function if people did this outcome. So I guess the question to ask ourselves now is, how was that achieved? What were the mechanisms by which that was achieved? So thinking back about the things that we've talked about today, we could probably put forward the hypothesis that people in this progressive exercise program were doing things like hopping, were doing things like jumping, were doing things that are more likely to address their concerns, their fears about doing these activities. So it's very possible that they had greater confidence from doing these activities. You could also argue that the loading was higher. So maybe the fact that they used these machine type weights that allowed them to progress the loading much faster, much better, that maybe was also another reason why they derived those improvements. So thinking about this study, I guess the initial way to explain that benefit might be, they just got stronger. Now, these guys didn't measure strength differences between the groups, so we don't know whether they did get stronger or not. Or you could say, the tendon got stiffer. But I think now that we have a greater understanding of some of the mechanisms, we probably would go more towards thinking about some of these psychological and cognitive mechanisms more likely as the thing that's going to explain some of the benefit that we are seeing. So we're now seeing this conceptual shift, starting to think about how can we provide the right environment for people to feel confident to load, to progress, to feel confident to get back to activities that they need to be doing. So one of the things that takes us to is how can we understand with the people that we treat in a clinical setting, how can we understand whether these people are the ones that we need to go that extra mile to understand how they're thinking about their problem and whether that needs shifting to actually allow our appropriate loading and our therapeutic exercise approach to work. So I'm just going to now share with you a couple of clinical findings and a couple of, I guess, ways that I would think about this in a clinical context. And this is work from Ruth Chimenti, who's out of Iowa in the US. She's done some real good stuff looking at kinesiophobia. And that's one of the things that I would look at routinely with people in the clinic. So sit them down, get them to do this questionnaire. It's only 11 questions, Tampa scale for kinesiophobia. It doesn't take long. You can do it on an iPad. You can do it with them in the consult. That takes a bit longer out of your consult time, obviously. You can then categorize them as minimal, low, moderate, or high kinesiophobia. Ones that are the worrisome ones are ones that are answering agree to these statements, which basically are statements about kinesiophobic beliefs. So pain always means I've injured my body. They're answering agree or strongly agree. You want to take them aside. Now, don't just focus on the numbers. Take them aside regardless of what the numbers are. If they've answered agree to any of these, it's an opportunity to try and improve their beliefs, their thinking about their problem. Okay? So that is quite a useful questionnaire. Another bit of work that Ruth has also done in this area, this is more recent, I think, where she's looked at getting people to seeing if there's a relationship, I guess the best way to phrase this is, between how much pain do people expect they will have and how much pain they actually have. And this is with, the top one here is with a calf raise and the second one's with a hop. And you can see that people who have got low, or classified as minimal kinesiophobia on the Tampa, they report a lower expected pain for these activities than people with high kinesiophobia. So that is another indication that someone might be kinesiophobic, how much pain they expect. And then lastly, are they actually at all willing to do the activity? So some people would just flat out, refuse to do certain things because they feel apprehensive, and that's also an important thing for us to pick up on. And if you're looking at high kinesiophobic people, only a quarter of them are actually willing to do things, or at least in this study were. So that's an important thing to take on board. So what it's telling us is that, these types of beliefs, these types of cognitions will actually influence how willing someone is to be active, how willing someone is to do things. And that's an expression of that you can assess even in a clinical encounter. Okay. So this is important because it's telling us directly about things that we can then utilize in our graded exposure rehabilitation to try and improve people's confidence, reduce the apprehension with movement. So I'm just going to talk to you briefly now about a couple of recent studies looking at education. So where this sort of takes us is now we're thinking more about psychological and cognitive factors. That's good. We also need to be able to address these factors with the appropriate type of interventions, and part of that is education. So this is another study by Ruth Chimenti where she's looked at education, and it was pain education versus pathoanatomic education, and they looked at a randomized trial comparing those two types of education. Now, there were many differences between them. So, for example, in pain education, there was pain neuroscience focus and more focus around, there's a lack of relationship between pain and imaging, whereas pathoanatomic education, there was a greater focus on the pathology, pathophysiology, and tendon adaptation, so more biomedical focus on the tendon. However, and spoiler alert for their findings, there wasn't a difference between the groups in terms of outcome. So they both got better. Yes, they all had an exercise intervention as well, but I guess where that takes us is, why was that the case? Why wasn't there a difference between the groups? One of the things that I think is important to note is that both groups were taught about what I would term appropriate loading, and this is where I want to come to the definition of one of the claims in this talk, which is appropriate loading is really important for pain. What I think appropriate loading is giving someone the license to be active regardless of pain, as long as they are conscious of their symptoms, not getting out of control. That is what I think in the tendinopathy context appropriate loading is. And both groups had that, and that's a really powerful thing to provide for someone. So if you're a trusted health professional and you tell someone it's okay, don't worry too much, you can do a bit of this, people do have, that's often enough for people, regardless of the pain neuroscience education. That's my belief. So I think that might have been one of the factors that then was enough for some people to take on board, to then be active and that reduce the differences, or the active components in the interventions that then reduce the effectiveness, between group effectiveness for this comparison. That's just my take on that. One of the studies that maybe lends some support to what I'm trying to argue there is one by Josh Zadro that was published in Pain in 2024. I was involved with this one, as well as one of my PhD students, Fernando, and in this trial, Josh had a big team of people, and he led this trial really well. And what we sort of devised as the interventions was, let's look at this a little bit differently. Let's look at giving people that license to be active, explaining that they can be active and that they don't have to worry too much. And let's see if the addition of pain neuroscience education actually makes a difference on top of that. And let's compare that to very structure-focused advice. And the important caveat on this is that this was an immediate effects trial. So we just were interested in, if you give this information to people, does that change their reassurance in the short term? That was one of the main outcomes. And what we found was that there were differences between this sort of control, structure-focused education compared to best practice education. Whether or not you had the neuroscience in there, it didn't tend to make a huge difference. So that, in a way, supports this idea that this, reassurance about activity and what I'm terming appropriate loading, how to be appropriately active despite pain, is probably really important. So that's a key message that I want to try and get across. Another thing that I'll just mention here, this is probably going into slight tangent, but we sort of view tendinopathy as a load-related problem. So we think that load is important. Most people have activity-related pain. Most people get worse, or one of the provocative factors for people is activity. But of course, load is not always the most important trigger. There are lots of other factors, lots of other biopsychosocial factors that can influence someone's pain. So one of the important things to identify is people that are not so much triggered by activity, because that will then lead to a slightly different approach. So we do use pain as a guide for progression, so don't push into too much pain. We tell people, make sure it settles within a day or two. We also tell people, but for some people, maybe we can take more of a time contingent approach, even people with tendinopathy, that we don't classically do that, and just load them gradually over time and completely ignoring pain. And clinically I do that pretty regularly with people if they don't have a load relationship between load and pain. So they're triggered by other factors. And then it's of course important to look at those other factors and deal with other issues that might be triggering their pain. That's just an aside to take note of, okay? So I guess where we've landed is trying to justify the second claim that appropriate loading, which is just a sensible graded exposure, doesn't have to be specific. It can be non-specific exercise that's just close to their goals, close to what they need to do. Progressing this over time is in my view important for pain, and that's where we're going to shift some of those beliefs, improve confidence, reduce apprehension, and get the best outcome for pain. As well as that, we can also address contributors, because there are going to be other contributors. It's not just that we need to get them tolerant to load. It might be that there are other things that we need to address. Now, by doing this load approach, we can address confidence, we can address self-efficacy, we can address psychological factors, and we might do some education for that as well. But there are a whole stack of other contributors that we also need to consider. So metabolic health, their general physical activities, stress levels, smoking, sleep, etc., social environment, work. These are really important activity patterns. So as well as what I've presented today, what I've talked about, what I've focused on is an active approach through this activity progression plus thinking about therapeutic exercise for adaptation. But there are a whole host of other things. I just wanted to throw in there and mention that these are also contributors that we should be paying attention to. So to wrap up then, I wanted to bring some focus on what I have talked about, and what I've talked about is different to, say, a lot of people will be aware of the work of Sean Hanlon, where he's done some sort of, I guess, groups of outcome impairments. So this is what this work is, looking at what impairments are present and how do they bunch together. What I'm proposing is that regardless of how people present, everyone's going to need an appropriate load progression, like a graded exposure approach. But then there are going to be some people, and that might be enough for these activity dominant people because they don't have many other impairments. But when you've got your tendon impairments and your neuromuscular strength jumping impairments, then you can add in a more specific rehab approach. So what I'm proposing is think about non-specific exercise to build people's confidence, and then think about specific exercise for bringing about adaptations when there are impairments, when we can demonstrate impairments that require that type of approach. Okay, so that's sort of how it fits into thinking at the moment about the whole gamut of impairments that are present. So in other words, look for the impairments that are specific, that are relevant, that you need to identify and address. So just a bit of a clinical slide to finish with. So this is now looking at how can we achieve optimal tendon adaptation and optimal neuromuscular adaptation. So say we do have these groups, these psychological dominant groups and structure dominant groups, which also present with impairments in structure like tendon stiffness and neuromuscular function. How can we achieve really good outcomes? Well, we need to load people sufficiently to achieve tendon adaptation. That could be concentric, isometric, or eccentric. It doesn't really matter. I use usually a combination of each of those, depending on the individual. Another thing that I did want to raise, though, is that there is emerging evidence that we maybe this cutoff of 70% MVC to achieve tendon adaptation is not absolutely necessary for everyone. So there's a recent study showing that even if we load people to 55% MVC, they're still getting, and that's maxing out at about 15 repetitions, they're still probably getting they're still getting tendon adaptation. Now that's likely to be because some people strain a lot at lower MVC levels, and that could be because their tendons are not as stiff. So there's a complex relationship between the loads we think we're putting in and the actual tendon strain we're getting, and that's something to take into account when you are loading as well. But that's an example of some repetitions and some dosages that I would use routinely in clinic to achieve tendon adaptation. The other thing you can do is heavy slow resistance, that will also achieve tendon adaptation when you're getting to the lower volume, higher intensity end of the spectrum. But we also need to think that neuromuscular adaptation, we need to train through the force velocity curve, especially training intent to move quickly, fast concentric movements, rate of force development, which is often impaired in people with tendinopathy. So think about some of those progressions as well as just the heavy slow resistance training, which we know does work for people. But I guess the take-home message from this slide is think about the prescription that you're going to use for someone when you're wanting to bring about tendon adaptation, how you're going to bring about neuromuscular adaptation that is specific to that person, depending on what activities they want to do and what their goals are. So adaptation is, tissue adaptation is really important. The key point is that it's not going to necessarily bring about improvements in pain. Okay, so the conclusion. So hopefully I have justified the two claims at the start. The two claims were that we can rely upon appropriate loading to make people feel better, i.e. to bring about pain improvements. And that, I think, should be the default paradigm, because everyone that we see comes in with pain, and that's the thing that they all will need, regardless of other impairments. When you've got someone that does demonstrate other impairments, then you're looking to adapt their tendon or neuromuscular adaptation, and that will help them to function better. So this is where adaptation is important. It's important for getting people to improve, and it might be the way they move, the way they can play sports, how high they can jump, how far they can walk without getting fatigued. Now, I'm not saying that pain and function improvement, tendon and neuromuscular adaptation does never or cannot have a role in pain improvement. What I'm saying, and I hope what I've tried to put across today, is that currently, with the evidence we have, they're not the big players in improvements of pain. Pain is far more complex, and I've just touched at the sides of some of that complexity today, looking at a greater exposure approach, focusing on kinesiophobia, focusing on improving confidence to load. Take-home message: strength and tendon adaptation may not be helpful for pain. So we shouldn't say to people, just get yourself stronger, your pain's going to improve. We should be thinking about a more nuanced explanation, and thinking about, I think, different paradigms based on the outcomes that we are trying to achieve. So thank you very much. Thanks for listening. I will leave it there. I've got my email address there if anyone wants to contact me, and I look forward to discussion and questions.